Welcome to Clinical Unfiltered. Today we've got a very special guest, the man, the myth, the legend, Dr. David Wong. Periodontist right out of Oklahoma, Tulsa.
Yep, you're right.
Tell us a little bit about yourself, David.
Yeah, man. So, okay, first of all, I'm about to hit the big 5-0 in 2 months. It's about to celebrate my 50th birthday. I was born and raised in Oklahoma. A lot of people wonder where the Southern twang comes from. It comes from growing up in Ardmore, Oklahoma, and I went to dental school in Oklahoma as well, the University of Oklahoma. I did my periodontics residency in Missouri and Kansas City. Moved back to Tulsa, followed my wife, which a lot of us do. She's got family here, so I just started up here, man. Just started from scratch.
Yeah, so I mean, you're an Oklahoman periodontist. I mean, that's where you started your practice, everything. Let me
Yep.
ask you this, man. You've been practicing longer than I have, and you've seen, and today's topic is going to be extraction and socket grafting, like
Mm-hmm.
straightforward, all the walls there, socket grafting.
Yep. Four walls.
You've been practicing. Let me ask you, through the years, has that process changed for you?
Yeah. Actually, it has. I mean, socket grafting for us. And now I graduated in 2002 from Perio, so 22 years. And I would say socket grafting was like one of the only surgeries that I learned besides like osseous surgery and free gingival grafts and connective tissue grafts. That was it. Back then, residencies didn't really value, you know, having us do a lot of implants or sinus lifts and all that stuff. I didn't even do anything with the sinus.
Oh, okay, wow. So there was a lot of heavy focus on getting the teeth out and then trying to preserve
The
the
socket,
bone. Yeah.
yeah, preserve the bone, preserve the ridge or whatever. Yeah, we would actually get in trouble for saying socket preservation. Like
Yeah.
that was like a big, like you're not trying to preserve the socket, you're trying to preserve the bridge. I'm like, okay, whatever. But I would say even when I first started lecturing about it, it was a shorter lecture, because we didn't really identify residency or for like any of my general dentist friends that I graduated dental school, we didn't really identify various socket morphologies. We just everything was just a hole, right? You take the tooth out, it's a hole.
Okay, wait. So you guys weren't like, hey, there's a buccal wall missing, there's a mesial,
Exactly.
none of that. Okay, so you
Didn't
just stared down the pipe and be like, all right,
There's a hole.
stuff it.
It's still a hole. Exactly. We
Oh,
didn't think
okay,
about
gotcha.
this is a fenestration. This is a bigger fenestration. This is a blown out socket. We didn't care about any of that stuff. It was literally like it's a hole. So then the question was, well, what would I stuff that hole with? That was the question.
Yeah.
And then of course you'd come into that's when we would get into the mineralized or demineralized bone or cortical or cancellous or whatever. And then of course it was just a matter of price. Like what's the cheapest stuff I can jam in there?
Even in residency though, in residency they were like, I'm assuming they were like, hey, put quality or like do what's the right thing.
Quality bone, but honestly, like I would say at UMKC, we played around with human allografts, but I mean we would stuff some xenografts in there. We didn't really.
Oh, I mean, I did too. I mean, and this was 2016, 15. It was like,
Yeah, we were stuffing xenografts in there. I mean, we weren't going. I mean, we knew the big rule was nothing, no alloplast. No bioactive glasses. No ceramics. We knew enough about that.
for the sake of the audience, why not? Even back then, like, what was the
So back then, it was like it doesn't turn over, right? It
right?
just stays and it gets fibrous encapsulated, so you get little tissue around it, and it doesn't turn over. So
But I feel like this is the thing, though. I feel like back then, the whole concept of ridge preservation it wasn't always geared around dental implants, right? Like sometimes it was like for Pontic site
right.
preservation. But I'm assuming implants were starting to show their face around that time, and they were like,
Yeah,
"Hey,
I mean,
this is for
I mean, don't forget, like ridge preservation in general has been around since like the '60s, right? So obviously, implants weren't around in the '60s that much. So the ridge preservation back then was, like you said, to preserve the literal ridge. We didn't care about bone. We just wanted
shape."
to, we just didn't want to like reline a denture every 3 months, So we
Right.
really wanted to preserve the ridge itself for removable
Right. It's like a
prostheses.
quantity game versus like quality. It's like you just want something there, physically
Right,
there.
right. And now it's different, because like it's like our talk that you and I did together last year at AO. We're trying to grow real bone and try to grow it fast too, so that we can, place our implants for hopefully a lifetime.
I mean, I feel like, for me, I feel like that sentiment's more impressed nowadays than it was even like 15, 20 years ago. Like the quality to quantity
Right,
conversation about when you're trying to preserve a ridge. It's like, nowadays it's almost like leaning like quality is almost more important than quantity. And you want both, obviously. It's like, what do you do to get that both mixed in there, that quality and the quantity of that ridge? But I feel like right now I'm starting to see, mainly because of periimplantitis, like seeing what happens when that, that's why you don't put ceramics into a
right,
socket. It's because it just won't give you that quality of bone, and as soon as you flick that inflammation on there, turns into fire. So,
right,
so you, I mean, you put xenograft in there too, and I did, and now I regret it.
right. But see, who doesn't regret it though, right? Everybody in Europe, where you don't even have allografts, that
Right,
they don't even have allografts available, so there's no human anything. They all they use is animal bone or autogenous. So you have those guys over there going, "Hey, we throw biolos in here for decades, and without any of the problems that you guys in the West say that you have." So there is still there is still debate there, on the magic formula, whether it's, a 4-to-1 ratio or 1-to-1. Like we still are playing around with
right.
it.
Like these guys are doing bio-loss or xenografts, and they're not
Yeah,
complaining about periimplantitis as much as we think they should be. So, like, what's
right.
up with that?
Exactly.
Yeah, yeah. What's up with
And
that?
so I think it's important, that we get kind of a global view of what's going on. Like not everything is just America.
Right.
So
Yeah, don't mind me with the red Solo cup and the Florida shirt today.
love the red Solo cup, man. I
It's
drink
just water,
wine.
I promise.
I drink wine out of red Solo cups, bro.
I know. I mean, that's what. I actually, when I talk about socket grafts, I don't, you were there. I always use the Solo cup. I'm like, this is your intact socket. If you take
Yeah,
the tooth out, so you say you guys were grafting. Obviously, you said it didn't matter the wall. You just grafted it, and I'm assuming that meant no membrane, or were you using membranes back then?
dude. Back in the day in residency. Now, keep in mind, I'm not saying that it's not like I was trained under Dennis Tarnow, right? I mean, I was trained under just you know, uh, a guy that graduated dental school from England, and here, got a teaching job at UMKC, and hey, I don't have anything else
From England to
better to
Oklahoma.
teach. So it's not like
Gotcha.
that's the other thing too. It's not everybody assumes that like every perio program's like Dennis Tarnow or Homley Wong. Like I mean, those guys are awesome, but those weren't the guys that trained me.
Yeah,
So
yeah, I got you.
we were yes, we did do membranes, but it really was not impressed upon us like how you do it, what type of flap design, if there's a flap at all, what kind of closure, how important that is. I will say that my instructors were awesome in regard to like letting us do things and try things, and they knew that they weren't, the perio leaders, so they would send us to conferences. So I would get stuff, I would get our information somewhere else. Um, so that was nice. That was nice. But as far as membranes, I mean, we had them and we used them, but we didn't really know.
What were you using?
We mostly used back then. We were using a product called BioMend and
Okay,
BioMend Extend. Something
gotcha.
that lasted a little bit longer. So we knew about that. We knew about the cross-linked and the non-cross-linked, membranes and all that stuff. But this is all. I was in perio from 2000 to 2002. So this is pre social media,
Right.
fucking internet. But I mean, it's not like you just
It
had
was
access.
dial-up internet then.
Yeah, yeah.
Internet as we know it.
It's not like you had access to all this information we had now. So I mean, information was getting to us, but slowly.
So the way you guys would use membranes then, similar to today though? Like, I mean, are you tucking it in the facial? Are you tucking it
Yeah,
in the palatal? Are you doing ice cream cones or stuff like that? Or no?
I'd say the predominant one that hasn't changed much is the ice cream cone technique. Where
Okay.
you cut a sliver of membrane that resembles an ice cream cone, and you slide it into the facial missing socket wall, or
Yeah.
a fenestrated socket wall. So that's the technique that the predominant membrane technique that we were using back then. And I would say that we still use that now.
I use it this week.
But yeah, but we also have, augmentation procedures now that we're adding soft tissue. We're adding other, things to it as well, just to get a better long term aesthetic result. But I would say back then we were still putting implants, not in the cingulum to the lingual. We weren't worried about screw retain. Straight to us meant in line with the incisal edge. So implant aesthetics was not as we didn't know as much.
You know, Sigmund Stahl, Dr. Stahl, he had some papers on histology, and he was actually Dr. Tarnow's teacher. This guy was like, man, this guy was he was older. I mean, he passed away, bless his soul. He passed away like maybe like 5 years ago, 6 years ago, but he was still teaching and he was living in like a condo in South Florida. So we would, as residents, hop on a bus and go see him in his condo.
Oh,
So
that's
you
cool.
can, and he had some initial. I mean, he had still that rotary device with pictures. Like that's how
Yeah,
we.
I have that.
Yeah, there you go. Yeah,
Dude, I trained on that. I was ready to take my American board exam with those carousels.
with those carousels. Wow, yeah.
I was the first class that, well, maybe the second class that didn't have the carousels. But I've got my board cases, two of them lined up in carousel.
You still have the carousel too.
They're in my office right now because I've got an associate now. I brought them out to show them.
But yeah, he had cases from when Stahl was a resident. I'm from when Tarnow was a resident with him, showing kind of the cingulum plate, like placing it a little bit more palatally, the
Yeah,
implants, and watching the how the facial plates would resorb.
yeah.
And he had these awesome pictures showing that and showing that, like, just kind of showing how the history tracked into
We weren't,
where,
yeah,
yeah, immediate implant placement and also how to just preserve the socket.
yeah. We weren't taught that at all, dude. And I even went to the Mish Institute when I graduated because I was like, I
Yeah,
don't think I got a very good implant education. I went to the Mish Institute, and Carl Mish was still teaching,
right.
cingulum. I mean, incisal edge emergence, maybe slightly to the lingual, but not like we do today.
And today, so today's socket grafts, I mean it's a very popular procedure. I want you to kind of walk me through like a simple extract. Like person comes in broken down number 8. Let's actually start at
No,
the front. Number 8. It's broken down to the gum line. What are you doing?
I think
Walls are intact. We got
yeah,
all walls intact.
all walls intact. I think the important thing is, like you just said, you have all walls intact. Rule number one is let's keep it that way,
Yeah.
right? So you want to be able to be able to, as atraumatically as possible, extract that root.
I use those the extractors that kind of dive in right into the center of the tooth and pull them out. You use them too, correct?
I'd say at the very, very bare minimum, you got to use periotomes.
Yeah.
You don't want those big fat elevators that even if you go to the lingual and you pop it out the facial plate, you don't want to do that. So I'd say at the very bare minimum, use those periotomes. But like you and I use, we use the root extractors, and I think various companies have those now. They also make, usually in most periotome kits, they also make like a little corkscrew type
Right. I've used
instrument
those.
that you can, once you get it luxated, you can, screw this corkscrew down to the root canal space and just
People sometimes are like, those don't work. Like, they break the tooth and I'll tell you, sometimes it doesn't, but like, I feel like when I get one of those, the corkscrew, well, not, I use, a Titans version of it. It's
Mhm.
called the Easy Extract, but basically you drill into it and you have like a little threaded device that goes right into the middle of the tooth where the root canal was. And if it doesn't engage and come out, often what it'll do is it'll fracture the tooth, almost like
Right,
a vertical root fracture. But then you got like two easier segments
right,
that can come out, and then it still comes out way easier than, well, maybe not as easy as grabbing and ripping and tearing, but I'm going to preserve more bone. The
right,
tooth is taking the beating, not the socket walls.
right,
And that's why I find it's the best way to get it out and preserve. I mean, that's your best bone. That's the bone you started with. They walked into your room and they've got some native bone, and I think it behooves us to like keep that native bone there because that's what's going to supply the new bone, and you just can't. I mean, nothing beats the bone you started with.
right. I think it's important, like you said, it's that's what's going to feed the new bone, but it's also important structurally, that you have, that a firm. a firm object, to condense around too.
Right. Oh, right. I see what you're saying. Like as far as stability and like
Yeah,
the past
that helps.
principles. Yeah, it's probably keeping that bone stable. So yeah, I mean, so you got all okay. So your tooth came out clean.
Rule number two is going to be you have to have a clean surface, right? So if you got a latent infection in there, or abscess, granuloma, or whatever, you got to get that out. So I think that's step number two for me is number one, clean clean extraction. Number two, make sure everything's clean in there. So you got to get your scalers, your rotary instruments, whatever you got to use. You just want to make sure that all four walls are clean. You
You
don't
got
want
all the above.
to leave a bunch of bacteria and granulation tissue down there.
What's your go-to?
For me, I always start off with like just a big, like a scalar. Either if it's a small tooth, I use a 4R4L. If it's a bigger tooth, then I've got like
Okay.
this little molt curette looking thing.
Yeah.
And then if I get really frustrated, sometimes you get those pieces of granulation tissue that no matter what, you're just moving it from one side of the socket to the other, and you
Playing
get
ping pong with it.
then I'll use rotary. I'll use
Okay.
rotary and get in there and zip it out real quick.
Putting on like a contra angle.
Either a contra angle, or sometimes if I get really frustrated about it, then I'll stick it in a high speed.
Okay, gotcha. Yeah, I mean,
With the diamond, and it'll come out.
I got this straight that goes on my electric. I mean, these burrs are like, I want to say they're like maybe 20 millimeters
There you
off.
go.
And they're great. I mean, then there's diamond balls at the tip. And those diamond balls, I mean, they're so convenient. And at this point, the assistants know I want them pretty much for every extraction socket. So I'm run that. Even if I feel like I got it clean, I run that. Because I do believe, like, I mean, you could do the most beautiful extraction, the most beautiful graft go in. And if there's crap in there, there's garbage still at the bottom. That's all you're going to get is garbage. You got to get it cleaned up. I use a laser too. I know. Do you? Yeah, I'll stick my laser in there and kind of run it around
Yeah.
and get it extra clean that way.
What kind of laser do you use?
I got a periolase, so an Nd:YAG
That's what I use
laser.
as well.
Yeah. And so like if it's in the room, like if the assistants remembered to bring it in and it's loaded up, and I don't have like an osseous procedure or a Lannat procedure, it's
Absolutely.
there. It's going in. Like I'm rocking it around.
I think it's the probably the safest laser to use without
Mhm.
burning a bunch of stuff up.
Right, right. Yeah, it's great. Yeah, because it doesn't get absorbed into like healthy light tissue like bone and good healthy gingiva. Okay, so you got it cleaned up. Now you got to pick a material, right?
The material. So, for me, the way I like to teach it is you kind of look at your bone graft materials. You obviously know you have your autografts, which I'm not going to use in a socket. Then you have what we talked about already, xenografts, which come from like animals, and then you have alloplasts, which are the glasses and ceramics that we said not to use. So that leaves you with allografts, right? That's the human bone. Well, the human bone's got now you still have a bunch of choices, right? You still have your mineralized versus your demineralized um, options. And then beyond those, you still have, do you want cortical bone, cancellous bone, or cortico cancellous bone?
Cortical bone being it's gonna stay longer,
Stay
slower
longer,
turnover rate.
has a
Yeah,
little, the particles are a little bit more robust, more stable. So that's where you get into the debate. I'd say a lot of people, if you said, I want to use human bone, no, not a lot of people are going to argue with you there for a socket. But I think there is some debate on what do you use. I personally use mineralized cortical bone or mineralized cortical cancellous bone is what I use.
gotcha. Now I mean, I always find it interesting to see how people have different dentists handle that conversation. But like, you got a patient who's like, "You're putting like dead people in me." What do you
Yeah.
like? How do you respond to those kind of patients?
So one of the things that helps is I always keep a bottle of it right at my
Okay.
consultation table. So I'm like, look, I want to demystify this for you. It's powder. All right, it's powder. You're not going to see an ounce of like this. Might as well be, table
Like we don't
salt.
got a dead body in the next room right next.
No dead body. I just tell them there's no blood, there's no guts, there's no protein, there's not a chance that you're going to catch a disease from any of this stuff. And that's kind of what. But I think showing them helps a lot because they see
Oh,
that powder. They're like,
that's a good idea. Actually, that's a good. I haven't done that. Like to actually have
that's
the
it.
powder. Yeah.
Yeah,
Yeah. I'm wondering if they're thinking like, oh, it's like a piece of bone. Like,
they do think it's a piece of bone.
my personal line, mainly because I'm in Florida, so everyone's like, everyone knows who knows Tim Tebow in the area. So I'm like, no, this is bone donated straight from Tim Tebow.
If that's the case, yeah, give me that Tim Tebow.
Right, give it to Tim Tebow bone.
Fast and strong.
No, I mean, it's funny. Everyone's like, it gets a little chuckle. Everyone like smiles and then they like forget their fears for a second. I can continue on to talk about.
Yeah.
Normally, I jump in because I use a lot of platelet-rich fibrin. So my next talk is normally like drawn blood. Do you use a lot of PRF or platelet-rich
Not for
fibrin?
sockets. I do for ridge augmentation,
Okay, gotcha,
but for sockets, I don't. I generally keep a pretty simple formula.
gotcha. So you got the mineralized cortical cancellous bone.
Yep.
Small particles, large particles, particle size matter to you?
Particle size for me, I just use small particles. Uh, Average particle size is around 300 microns.
Okay,
So we always just, whenever I'm nerding out and talking to people like you, I tell people don't get particles over 1,000 microns because they're too big and they'll get fibrously encapsulated, just like your xenografts will.
yeah.
Nothing, nothing smaller than 250 microns because and then it's literally powder and it'll just
Right. There's dust in the wind. It's like you're gonna watch it kind of flow off, kind of flurry away from your bottle when
yep,
you open it.
yep,
I've noticed though some companies have made like they're some are better at kind of getting it to the smaller size range, and some I feel like will end up a little bit more all over the place. And I've
right,
played with a lot of different ones, and I've kind of most of mine is Puros, and then I mean I don't want to say that's probably like 90% of the allografts that I'm using is coming from Puros. I feel like they're very consistent in their particle sizes, so I'm not getting like a huge random range of it.
right.
Um, which it's like that's the difference. I feel one of the differences I've noticed between different allograft companies, and I feel like that helps is to have it, uniformly a good shape. And so you wet it with saline, blood,
I'm a sterile water guy.
sterile water. Okay,
Sterile saline I think is better,
yeah,
but I think sterile water for us came about as a practice management thing because a lot of our patients aren't sedated. So anything that tastes less like blood is what I want to use.
gotcha.
So that's where we ended up doing that. It's just a practical thing, no scientific.
Right, I gotcha. Yeah, it's practical. Well, I mean, that's a big part of it. I mean, we do a lot of sedation, but um, for us because we're using the blood concentrates, we're just using blood. We're just using the flavor. So we get it. We create the sticky bone essentially, even for the socket graft. So we pretty much have all our assistants phlebotomia trained, so they're drawing for everything. Like crown lengthening, I'll have a slate of PRF on the table, and I'm like, what am I supposed to use this for?
Right.
But for socket grafts, it does. I honestly, for anything else, the handling properties, it's nice to kind of like pick it up as
Sure.
a clump. It's almost like a block graft at that point, like coming up as a clump and falling into the
Yeah.
socket, and then it creates that last layer, which for me is PRF. What do you? So you got the sterile water graft. You're scooping it in.
Bones in.
Um, Bones in. Are you pressed to like get it into every corner of the socket, or are you like if I miss a corner, it's okay?
I I do try to get it everywhere because for me, I like that just because I think I'm still a dentist at heart, so it's almost like a composite or an amalgam if you're my age, or if you're doing endo,
You still got skills, yeah.
you can see voids, right? But the
Yeah,
other thing is, if I see voids, I always worry that I didn't get the socket clean. That I leave a big
right,
chunk of granulation tissue there, and is that why it didn't go all the way
right.
down? Now,
It's like a confirmation, like, oh, okay,
yeah,
when I'm
yeah,
looking at the X-ray or the cone beam afterwards, I know I got it cleaned up. Everything there is probably there.
makes me feel better. It's just all about the feels. I don't go take a CAT scan afterwards or anything like that, but I just do a PA.
Yeah, more so like when you're planning for an implant,
Yeah,
afterwards, and you see a void, you get worried,
yeah, you're
like
like,
if you see a void at the bottom of the apex, and that's honestly my reasoning too. Is everyone's asked like you don't have to. I'm like, yeah, technically you don't need to graft the apex of a socket. That's not where we struggle. It's the crestal portion really.
right,
Um, and but for visual confirmation that I had gotten everything clean, gotten that is huge to me. Because I do feel like you see retrograde periimplantitis come from like old infections that have lingered for years and creep back up on your implant. I feel like that confirmation visually is helpful. The same reason we might use like a radio opaque bone in the sinus to confirm, you know, we got stuff in the right place.
right.
Um, yeah. And so do you put anything over it? So you got it in the socket.
Yeah. I would say for a four-walled socket, I mean, I would say up till about 5 years ago, I would just, if it's a four-walled socket and it was a good four walls, I mean, not thin, just good four walls. Let's say it was a molar, I would either do nothing or I would just put like a little piece of, collar tape or something over the top.
Right.
I would say nowadays, you know, um, I've got all these companies like sending me stuff and like try this membrane, try that membrane. So I would say nowadays I'll tend to cover the coronal part of it with a membrane
Do you
just to
focus on like,
see if the soft tissue closes over a little bit better,
gotcha.
see if the crest of the bone heals a little bit better. To be fair, I feel like I see a marginal difference, but
Okay.
not to
Gotcha.
where I'm like, God, I mean, I'm not going like, hey, I can't believe the first 15 years of practice I wasn't using a membrane for molars.
Right.
I was
Right.
really, I was really screwing people over. I don't feel that way, but I think I've definitely started using a membrane a little bit more.
Yeah.
I think the studies are we in one of my courses with there's a study that I quote that does show using a membrane even in a four-walled socket does improve your outcome.
I think, yeah, the general body tends to support.
Yeah,
And you know what? When you look at the studies, a lot of times, like, what I mean, you got to consider what's marginal. I feel like some of them are like it's 1.5 millimeter. They're like, they are
marginal.
seemingly still marginal, like from a clinical standpoint. When you look and you're like, it's a little bit better. I feel the same way. I'm like, maybe. And of course, it's the healing potential of the patient too. And some people, you leave it open and and it looks like it's closed. It looks like you had primary closure on it a week or two later. And then
Right.
some people you close it and it looks like it opened up a week or two later. But I feel like when I use like the cross link to the ossix membrane and I do tuck it on into each side, and when I end up, I feel like just the nature of trying to create a small little gap to slide the membrane ends up mobilizing the tissue a little bit
You like
more.
that better? Yeah.
And not all the time. I mean, I feel like in 8 or 9 I don't, like I don't want to lose that soft tissue profile, because you get a little bit of collapse there.
Right.
Those I'd rather even like have a Pontic Essex in there. If I'm not, I mean, I do a lot of immediate implants. I feel like that's the best socket preserver ever.
Yeah.
But I'd rather have a Pontic in there, and like that's why I like the PRF, because I feel like it doesn't fill up that space too much. It's compressible, and so it'll kind of stabilize the graft as I can put pressure on that PRF, and I know that platelet-rich fiber and it's gone. It's almost like I'm not really putting anything on top of it, and
Yeah.
I can maintain the soft tissue. But in the posterior, I do kind of like that tissue coming in a little bit closer together from
Right.
creating that localized flap and then tucking a membrane. And I do feel like when I do get the Ossix Plus and I open it up, I'm not seeing as much of those particles within the soft tissue.
Mm-hmm.
I'm finding that the bone is almost more delineated from the soft tissue. And I'm mainly using the Ossix Plus. That's like my go-to for the most part.
Right.
When I am when I am using a membrane. Otherwise, most of the time I'm just using PRF. I mean, even in the posterior.
I think for what you're talking about, we've been using Ossex Agile quite a bit because you can tuck
Okay.
it without tearing it a little bit
You
better.
know what? I have slowly switched to the Agile. I've
Yeah,
slowly,
because
just for that sake, just for like
yeah,
being
you
able to
can't
get it in
tear it.
there.
It's
Yeah.
almost impossible to tear. But yeah, so if you want to tuck with something, it doesn't. You don't perforate through your membrane.
I think it does help to have a membrane that isn't going to break up on you as easily when you're
Yeah.
tucking in, for the sake of like minimizing a flap, which what you want to do. You don't at this point with a simple socket graft. Your goal here is create something, but don't create too much trauma, because you've limited that as much as possible. You got a shot at this patient enjoying the experience.
Yeah, but these scenarios are really fun, for experimenting with membranes too. Like we've been doing a lot of like amnion, chorion too.
Oh yeah, like the bio-exclude membranes.
Yeah,
Yeah,
um, yeah. I think Salvin's got them.
yeah,
Everybody's got
yes,
them now,
someone's got
but I mean they're
yeah.
so thin, so that's kind of nice too, just to try to play around. It's a good opportunity to see what works well in your hands and see what materials work great for you too.
You know what? You're right. I have seen with those amnion chorion membranes, because it's almost like you're getting like a barrier function on top of like the PR. Like when I use platelet fiber, I'm not really getting a barrier function. I'm just trying to promote soft tissue closure, really,
Yeah,
and handling properties. But
which for a socket, that's fine.
that's fine, right? But the amnion chorion might actually give you that kind of like junction of like, hey, some barrier and some biologics to it as well, which is an interesting and good choice. All right, man. Anything else you want to add that's like a pearl that you think is critical? It's like to socket grafting.
Man, I think that's really it. I mean, the only thing we need to touch on after you do that, add your membrane or not, most of us put some type of a figure eight suture or something over the top of that just to kind of adapt it, even 1 millimeter closer on the edge.
Let me ask you, what suture are you using?
For a four-walled socket, I just use chroma gut.
Gotcha.
Yeah. If anything else, I'm using PTFE right now. Um,
Okay.
just because once again, running a business, it's come down in cost a lot.
Yeah.
So it's cheap now and super easy and very kind to the tissues. So
Have you ever used like a monocryl or a
I have
glycolon?
I
Okay.
use my monocryl as well for a long time, but it's on occasion we get patients that would complain about it sticking their cheek and being too stiff. But once again, it's a nice suture as well. I think the PTFE holds a knot a little bit better and it's not as stiff. But
I feel like I can put a little bit more pressure, and I feel like it does, and not like kind of stays put, whereas the
yeah,
glycolon slips just a little bit.
monocryl works great. We've used
Yeah.
glycolon a lot too.
Yeah.
But there's a lot that work out really well.
You ever use glue, periacryl on top of a
I
socket?
haven't, man. I'm
Yeah.
trying to like minimize my steps and stuff and not have so much stuff out. But
Right.
but a lot of people, they'll use they use periacryl for that purpose, just to kind of make sure that their stuff doesn't get untied.
Now I just reminded me of one concept too is use because I mean particulate is obviously the overall go to, but utilizing like block or like whole grafts or like the osteogen plugs I get a lot of times
Yeah,
BioOS collagen, Ossex bone, the ones that come in like one whole piece inside sockets. I've used some, been hit or miss. I feel like I always kind of revert back to my particulate
yeah.
socket grafting, but some of them are interesting. I mean, they're interesting concepts. I think they're designed to obviously be easier to use. I mean, have you played with them a little bit?
No, a little bit, but most of those BioOS collagens, you have Mineros X plugs. They're all for whatever reason they're all xenograph plugs. So I'm like, once again, it doesn't really
Right,
jive
right.
with how I like to do it. Now, one thing that I have seen, you made a comment earlier about we don't really worry about bone in the apex, which is true. So a lot of what people do now is they'll cut a collar plug in half, stick it in the apical portion where we don't have to worry about it, and then they'll graft the rest. And they say that works. I haven't. I mean, I'm like, theoretically, it should work really great. I have not tried that, but
Yeah, neither
I
have
know
I.
that's trending right now.
I know, but honestly, for that same reason, it's like my confirmation of the socket being clean is all dependent on that apex showing up a little bit radio opaque
Right.
when I when
Yeah.
I when I graft. And I know you're going to do a college plug, you're not going to see that. You're going to see probably a little void there
Would.
because it is lower density bone at that point.
Yeah.
Probably better quality, might be vital if it did heal properly. And again, like that whole concept of like creating vitality versus quantity of bone, like quality over quantity. But I do, yeah. I think if you're picking up a xenograph like a particulate, drop it, use it for something else. Don't shove it in a socket. Preserve the bone as best you possibly can to start with. Try to end up with a four socket wall. Because we're going to talk about, I mean, on other talks, we're going to talk about like broken down sockets, which are much more, they get more complicated if you really want to regenerate bone. So keep it clean, keep it atraumatic. And then honestly, it sounds like we can get away with most things inside the socket at that point.
Well, Saga can almost do anything. Like people try to start arguments, it's really not even worth arguing about.
Right. Stabilize a blood clot. The body can do it. The
Yeah, for
body
real.
showed it could do it. And if you were a new dentist wanting to like advance your techniques on socket graftings, what do you like? What's your recommended go-to places?
I'm just gonna have to raise my hand and say myself probably, and me and my buddy Curry Levitt, we do a course twice a year in Las Vegas. I feel like we do an awesome job at it. Just you know, think about this podcast here and times it for by 8 hours and throw in some live surgery and your pig jaw lab and suturing techniques.
And what happens when things go wrong?
Exactly what happens when things go wrong, and then of course ongoing support with us. I feel like we do a pretty good job there for a pretty reasonable price as well.
Awesome. Best way to reach out and get to it? Is there
Yeah,
like a link or go straight to you?
yeah.
Man.
Go straight to me on Instagram or the link to the course is on my Instagram bio, but
Gotcha.
they're done through the OR Foundation. So it's the
Okay.
www.orfoundation.org, and they have a list of all the courses. But everything we do, everything on there is less than $2,000 for the weekend.
Oh man. All right, man. That's what I'm talking about. Thank you, David. Thank you so much for sharing your pearls and giving us some more resources. Again, we do this, there's no sponsors. We're not making any money on this. This is just for the love and art of dentistry. And your likes, comments, sharing it, that all goes a long way to keep us going. Thank you guys again, and have a very good gym or car ride. Bye, guys.